Welcome. We are live. I want to first thank our committee for coming, for being on time. If we start on time, we can get out early, right? And after the briefings, we have bill hearings. And I believe we have today 4 bills, okay, as well. And I want to thank everyone at home who's watching us. And those of you that are here today, thank you for your time. Staff, thank you for putting all of this together, okay, for all the work you do for us. So good afternoon. My name is Jocelyn Pena-Melnick, and I chair the Health and Government Operations Committee. To my left is my amazing vice chair, Delegate Bonnie Collison. I'm going to go through some of the rules. Please remember to be mindful of all conversations that may be picked up by the new closed captioning, because it's an amazing thing, but it does pick up your conversations, and maybe you don't want that conversation out there, right? And we are actually already live. I would like people to turn their phones off, and I'm going to do the same. And as the panelists testify, their presentations will appear on the pot screen in the center of the room. The panelists will control the transition of their slides. If you need help, let us know. Before this briefing, to my amazing committee, you were sent all the briefing materials. If you need it, please let us know. After each presentation, committee members will have an opportunity to ask questions. After the whole panel is finished, please press the microphone button when I call your name to ask a question. Please wait a moment while the staff turns on your microphone. Please adhere to our 1 question and 1 answer from the panel, not 1 question and 1 answer from each panelist. And keep your questions brief if you're able. Keep in mind that this briefing is live on YouTube and the General Assembly website. Immediately after this hearing, we will go into bill hearings as well. So good afternoon, Madam Secretary. How are you?
I'm wonderful, especially since I get to be here with this committee and with you, Madam Chair and Vice Chair. And
thank you.
I am so appreciative of the opportunity to brief you on the Department of Aging. I'm going to be sharing our department's vision, mission, and role, and how we work with our aging network, including our 19 area agencies on aging. I'll review what we've accomplished this last year in Maryland with your constituents, and I'm going to briefly tell you about our Longevity Ready Maryland multi-sector plan for aging and the changing demographics in our state. So our vision for the Department on Aging is to transform institutions, systems, and norms so all older people live lives that are healthy, financially secure, socially connected, and purposeful. And this is the real important part, the tagline, for the 100-year lifespan. So we are focusing on longer lives. And what we know is there is no real benefit to a human being if they live to be 100, but they are not in good health. They do not have the resources that they need to live a safe, secure life. They're not connected to society, and they don't feel that they have a purpose. So that's why we chose those 4 domains. Our mission is to prepare for the growing population of older adults by developing innovative approaches to aging, advancing multi-sector collaborations, and providing equitable access to resources. So we're looking not only at individual aging, but we are looking at the aging of our society here in Maryland. The role of MDA is to serve older adults and those with disabilities, their families, and their caregivers. I never talk about older adults in Maryland where I don't talk about their families and their care providers, because that is the unit that we need to be thinking about when we're serving older adults. The aging, our role is therefore to administer funds, federal and state, but also we've been tasked with establishing priorities, planning, advocacy, legislation, and policy. And this is something that we've taken very, very seriously under this administration on behalf of older people. Next slide. So we do this with an aging network. There's no way that the Department on Aging with 50 employees can do all of this beautiful work alone. We do this through our network, which starts with the Administration for Community Living on the federal level. That is our federal funder, housed in Health and Human Services at the federal level. We work through, we are the state unit on aging, so we've been designated to work on behalf of older people in Maryland. And then we work with the area agencies on aging. They provide the services. We provide funding, policy, legislation, planning, and expertise to lead the network. So at the local level, the services that are provided to older Marylanders include access to services. So a lot of that happens through our Maryland Access Point, nutrition services, and actually that is the beginning of serving older people in this country. It was really oriented around feeding older people who are in poverty and were going hungry. And that's something that we still do. We do home and community-based services, chore services, et cetera, adult day services, and family caregiver support. We work on teaching families, older people, and care providers about disease prevention and also maintaining health. And then we work very closely with a national ombudsman, which is housed in our department, to make sure people who are living in assisted livings and nursing homes receive the care that they deserve. Next slide. So I have a budget slide up here, not because we're going to talk so much about the budget. I know that's not what this committee focuses on the most, but so that you'll be able to see sort of in a snapshot, where do the funds come from and where do they go? And also so that you can understand that the Department on Aging is a small agency in terms of people and funding. And you know, most of the funding that actually benefits and serves older people in Maryland does not come through the Department on Aging. It's in housing, labor, transportation, health, disabilities. And that's why we work collaboratively with them. And that's why we need to be present, always reminding our sister agencies that older people need to be considered and considered a priority when they are using their funds. Next slide. So here are some of the things that we've accomplished over the last couple of months. We've worked really closely in partnership with other agencies and organizations. And the reason for this is for what I just described. We are not funded at a level, and we do not have staff at a level that really allows us to get meaningful, purposeful work done unless we do it through our sister agencies and through the network. And we've leveraged in-kind funding so that we can more effectively serve older Marylanders. So we've received funds that let us do things like work to do a better job of creating programs and services with our sister agency that best serve older people. And so we've had technical assistance grants, and we've gotten other kinds of federal and state funds that help us do that kind of work. We've also promoted evidence-based strategies for reframing aging. And for those of you who don't maybe know it the way we do in the department, ageism is one of the greatest hurdles facing older people. And one of the things that the World Health Organization, which I know we no longer belong to in the United States, but the World Health Organization issued papers related to this and actually said ageism is the thing that is preventing the kind of changes that we need across society to occur. And so we did a lot of work with the Center to Reframe Aging. We educated about 600 people on ways to talk about and think about aging that are more inclusive and more complete than the way we tend to think about it now. And then we've invested in community-based efforts to reduce isolation and prevent higher care needs. And this has been a strategy that the department has undertaken, which is to focus very much on hyper-local providers with funding and technical assistance to try to build more resilient communities at the most basic level, ensuring that older people are being included and cared for appropriately. And we think this is one of the ways that we're seeing some good outcomes from those investments, particularly when it comes to the village model and to some of the more hyper-local social services. So we have some legislation. I'm going to talk about that in more detail in the hearing that's coming up. One of the things that we've been very, very concerned about at the agency level is looking at our programs and services, some of them which are 40 and 50 years old, and recognizing that many of the programs, services, and systems that exist today to serve the population of older Marylanders were created during a time when the population profile in Maryland looked very, very different. And that we're still trying to do the same thing in the same frameworks, and recognizing, A, as that number of older people grows, but also as that population looks very different, they no longer serve. And so we said, what can we do to begin to look at all of the programs and services that we're responsible for funding and providing assistance to our local AAAs to deliver programs and service? How can we improve them? And when I think about improving, it isn't just efficiency and effectiveness so that the dollars go further. That's really critical. It's so that the services that we're offering actually have the impact that is significant for the older person, their family, or their care providers, and not just something we think might be good for them. And so we're moving toward a very person-centered approach. And what these two pieces of legislation that we'll talk about in much more detail really are about is getting to that efficiency, effectiveness, and really meeting the need of the people that we are serving. So I'm going to talk a little bit about why is this something we're so concerned about? Why is there a sense of urgency now? So Maryland has a population of around 6.7 million people. We're not, in terms of population, a very big state, actually. We have 1.2 million people who are in the age bracket of 50 to 64. Those are the younger, older people. And then we have 1.8 million people who are over the age of 65. I will have to share with you right now that I have a bias in that chronological age really doesn't tell us very much. So I'll be 70 in a couple of months, and I have a hard time sometimes understanding who we're talking about. That's part of what Reframe Aging helped me about, which is, no, I'm talking about me. I'm talking about us, not some people over there. So one of the things that we're looking at is that we have 50 million people. We have 2.3 million people who are 50 and older. And why do we care? That'll be 37% of the population. Because if you're 50 today, in 10 years, when we're at the end of our multi-sector plan, you'll be 60. And that's when we know all kinds of things start to perhaps be more daunting for the population. And we know that we need to think about our older population differently. Next slide. So here we are living longer. This is one of the incredible blessings of modern life. It's happening all across the world, all across the country. We are living longer. And right here in Maryland, we are fast approaching a time in 5 years when 26% of our population will be over the age of 60. Next slide. This is the one that gets me really excited. I have grandkids, so I think about the world today, the world tomorrow, and the world after that. Half of today's 5-year-olds can expect to live to be 100. And we're starting to hear a lot about, centenarians, people who've lived to be 100. We've only just begun to see that population. So that tells us that we need to be thinking differently about the life course. Because if you live to be 100, when you're pushing 70 like me, you have a long roadway ahead of you. And hopefully it will be full of challenges, but also tremendous opportunities as an individual, but for our society. Next slide. So we looked at that and we said, maybe we need to think about not just older people today, but think more generally about what does this mean for our state? That more than a quarter of the population in 5 years will be over the age of 60. And we worked with the Center for Healthcare Strategy on a multi-sector plan for aging. These plans are becoming more popular across the whole country, and there's actually a national plan in place now. In centering the values of transparency, inclusion, and person-centeredness in the structure of that plan. So this was not something that the Department on Aging got together and said, ooh, this is a great idea, let's work on this. We went out and we talked to our stakeholders. And we did significant stakeholder engagement during the past year, and we also did stakeholder engagement in a very systematic way. So not just generally, oh, let's talk to that group or that group, but with this idea of being inclusive in our framework. And the work group participants helped us come up with 4 EPIC goals, 14 objectives, and 76 strategies. And that 76 strategies actually has been honed down from many more strategies than that. But, I take a deep breath when I see 76 strategies, and I say, thank you, Lord, that we have 10 years. We're going to need it. Next slide. So these are our EPIC goals. And by EPIC, I just mean bigger, biggest. We looked at building a longevity ecosystem, and I know that's kind of insider talk ecosystem, but mostly it says we want to make sure we're helping to build communities, services, systems, institutions that are going to be able to collectively build capacity at the local level to serve older people in Maryland. And we looked at the priority area of promoting economic opportunity, because if you remember back to our big goals, for Maryland, this idea of being financially secure in late life and across all of life, actually, is something we're focused on. And so we know we need to look at caregiving and care workforce, and we need to look at multi-generational workforce. And this is something our labor department's working on very hard right now. And we're also looking at people being able to be happily and successfully employed past age 50. We're also finding ways under preparing Marylanders for longevity to be able to afford housing, health care, and have the financial security for those extra years of life that we now are blessed with. And what we know is that most people in this country and most people in the state of Maryland do not have enough personal savings to last through their lifespan. And this is, it's like a crisis that is sort of, the water's heating up. It's going to be boiling soon. And that's one of the things we want to work toward. And then, of course, we really know that it's about being able to be healthy enough to enjoy your life. And so we're really working on those kinds of things that maximize people finding ways to have healthy lifestyles, participate in their communities, find ways to get to programs, services, and social activities that they want to participate in. And we know brain health, as it's now referred to in the modern vernacular, is really critical. I lift that up because part of my life's work has been caring for people with dementia, their families, and care providers. It is an expertise that I have, and we know that Maryland has a disproportionate number of people who have Alzheimer's disease, particularly in our communities of color. And it's something that we have to address in a very targeted way. Next slide. One of the ways we're going to try to be transparent and collaborative and continue to engage the multi-sector is to have a Longevity Ready Maryland data dashboard. And, you know, for those of us who can get really nerdy, this is a very fun topic. And we've had a lot of help from the planning department and from our sister agencies who collect all kinds of data. And our goal is to have a data dashboard that will go live sometime in the spring that is refreshed frequently. So not just, you know, people who are in government and people who are in state agencies, but the general public can go to and learn about what's happening in Maryland and how is Longevity Ready Maryland progressing. And we hope that this will be interactive and will help us stay engaged with the many hundreds of people who've already been involved with Longevity Ready Maryland. Next slide. So here's the timeline. You know, I have to admit, I've been working on Longevity Ready Maryland before I became the Secretary of Aging and made many good friends and talked to the governor about it during the time he was asking me would I come out of retirement, whatever that is, and become Secretary of Aging. And we did have an executive order that was signed about this time last year. We've been doing this extensive stakeholder outreach. And in March, the draft plan will be ready for public comment. And then our hope is that our plan, which includes our 4-year state plan from the Department on Aging that we must hand up to the feds, our Longevity Ready Maryland plan will be signed into acceptance at that point. So this is all about collaborating, working together, so that older Marylanders, and in fact, in my view, all Marylanders across their full life course, because longevity is about the full life course. It's not just about the last 5 or 10 years. They will lead lives that are healthy, so financially secure, connected to their communities and their loved ones and families, and purposeful. No one will ever think, why should I live? Why bother? And I don't want to, you know, leave on a downer note, but older people commit suicide at higher rates successfully than any other part of the population. And that says there is an issue around purposefulness that needs to be addressed. So I guess you can tell I'm very passionate about this. It is indeed my life's work. I am so grateful and so privileged to be able to be the Secretary of Aging and to work with all of you. And I have the let's collaborate gene, and so that's what I'm hoping we're going to be able to do with this great work on behalf of older people in Maryland. Thank you very much.
And thank you. And how can we get that gene to spread? Anyway, I just want to say thank you so much for your passion and your commitment, which is so important. I am really impressed by your work. I know you and I met for lunch in the interim, and I love the fact that you keep us informed. And considering you only have 50 people, right?
Yeah.
You do a lot. And I think that the idea of working with other departments and making sure that you insert yourself, it's a great way, especially when we lack resources. I really appreciate it. I have one question, but I'm going to wait to the end and see if my members ask it. And let me open it up for questions from my members. I have Delegate Olston, followed by Bandari. I always forget Delegate Kipke, want to make sure. See that light? Okay.
Thank you, Madam Chair, and thank you, Madam Secretary. It's always such a pleasure to hear you speak, and your energy around aging is infectious, so I just wanted to thank you for that. I wanted to get your opinion. I believe it's either the state of Washington or Oregon that requires the purchase of long-term care because of the extended lifespan that we're expecting people to live longer, and we know they're not financially prepared. And I just wanted to know your thoughts on that. And great job with everything that you all are doing, and thank you for your hard work.
Thank you for that question. This is actually something that at the department we have had some internal discussions on, and different states have taken different approaches to this. Washington in particular really came out in front and worked for a couple of years on structuring a program where everybody pays in to a system that when they need it in later years, they can draw on those resources for long-term care services and supports. I think that what we are also aware of, not just in Maryland, but across the country, is that the long-term services and supports network is not really in existence. I was going to say it's not strong, but we really don't have one. And, there is some sense of urgency about coming up with innovative approaches that are financially doable, that would serve more people in later life. Private long-term care insurance is prohibitively expensive for most people. And the other alternative is to become truly impoverished, and then the choices there are limited. So there's some home and community-based services, but mostly it goes to paying for nursing home care. So we're very interested in, as part of the Longevity Rating Maryland program, actually beginning to explore what are our opportunities around this. And I like that some other states have gone first, because it gives us something to kind of look at and test out. So thank you for that question. It's an excellent one.
Thank you. Thank you, Madam Chair.
We have Delegate Bandari.
Thank you, Madam Chair, and thank you, Secretary, for a wonderful presentation and your character, commitment, and confidence. Regarding the Longevity Rating Maryland multi-sector plan, could you elaborate on how the department plans to address the specific challenges, not challenge, opportunity, I would say, by Maryland changing demographics? Now there are close to 500,000 Asian Americans, and Latino population is increasing as well, particularly in promoting holistic healthcare and reducing social isolation among senior adults from onwards, like in 15, 20 years from now, they will be in the senior centers, and they have not been long in our state. So is there any plan to address that?
Thank you for your question. There is a plan. I think it's about 70 pages long right now. But I want to speak specifically, if I may, to this issue of social isolation. And one of the things we will talk about in our testimony later is the need to really address this social phenomenon. It's not specific to older people. It is something that's happening in our society overall, where we are not, the fabric of our society that has held us together and allowed us to connect easily with one another doesn't exist anymore. And we are entering sort of new territory. So what the department has done is taken the issue of social isolation, which is brought on by many people living alone. About 10% of the population in Maryland over the age of 65 lives alone, but correspondingly, so does the population under the age of 30. So what we're seeing is youngsters and oldsters, or youngers and olders, as I've been told, are experiencing this in the same way. And what we think needs to happen is that we need to find ways, both through our senior centers, but also through the work we're doing at sort of a hyper-local level in community with existing networks to leverage what's already there and strengthen those. I don't want to get into a whole topic about our healthcare delivery system, but I will say it currently does not really promote the kind of lifelong good health we would like to be seeing. And so a lot of the work that ends up happening is sort of after the fact, when people are living, into their 80s and have multiple chronic diseases and are alone and maybe experiencing frailty. That presents a very unique issue. And so there are parts of the plan that are going to address that specifically, and we're happy to share that with you after the briefing. But for right now, it really has to do with some of the programs and services that we are putting into place. And you will hear about some of that right after this in our briefing.
I have Delegate Hill, followed by David.
Thank you, Madam Chair. I guess it's really a follow-up on Delegate Bandari. You talked about the importance of making it possible to have people who are aging continue working for longer when they want to, and ageism and how that impacts it. But at the other hand, at the other end, we have young people who are concerned that they can't get jobs because people my age are continuing in jobs. And just as the housing issue is squeezed at both ends, do you have any thoughts or comments about how do we deal with that stark reality, particularly in a time when, with automation, jobs are becoming fewer and tighter?
Thank you for that great question. So I think there is an assumption that has not been well-founded in data that older people are keeping younger people out of the workforce. The truth of the matter is we don't have enough people in the workforce at all. We are not going to have enough people in the workforce. And what has been happening in some countries that are taking this on in a sort of more progressive fashion is that they are incentivizing and finding ways to encourage private sector to understand that older employees bring all kinds of advantages to the workforce, but where you really get the bang for your buck is when you have a multi-generational workforce. And there's really good data on that now. And I'd love to share it with you and have more of this conversation, actually. But there's good data that shows the private sector organizations that thrive and do the best are the ones that have very intentionally promoted a multi-generational workforce. And that doesn't really solve the concern, I think, because something's happening if younger people aren't getting jobs. But I don't think it's that older people are standing in their way. And that's something we talk about a lot at the Governor's Workforce Development Board. So what is happening? What we do know is even if all of us stayed in our jobs forever and all of the young people got a job, in the current economy, we don't have enough employees. So I think, well, I could go on and on. This is a topic I'm very, very passionate about. I would love to talk to you about it. Thank you.
All right, thank you.
I think she has your number.
Okay. And if she doesn't, may I give it to her?
Oh, yeah.
Okay, thank you. Delegate Taveras.
Thank you, Madam Chair. I have 3 brief questions. May I?
I'll brief them.
If you go straight to the question.
Yes. What, compared to where we are now with home-based care needs, compared to where we will be, what is that gap by 2030? That's one.
It's big. And I say it that way because I'm very wary of quoting statistics when I don't have them right in front of me. So can I get back to you on that specific question with the data that is currently available? I will say that we know that we have wait lists in every program for home and community-based services.
Yeah, that's one of the reasons why I asked. One of the things that I saw in the community was that there was an increase in STDs and such in this particular community. Is there any activities around that to address and mitigate these issues?
So the Department on Aging doesn't specifically address healthcare needs. Those tend to be in the Department of Health. But what we can do, and what we do work to do, is to reduce stigma so that there is a sense of people feeling welcome to talk about whatever the issues are, and then try to get them connected with the resources that can better serve them. And I actually love this question because it goes right to the heart of the bias against older people. We know older people don't have sex. So how in the world can they have STDs?
They get busy.
So our work with Reframe Aging is, oh yeah, they do, and oh yeah, they can, and it's a rising issue. But it is very much a health issue and something that we work to reduce the stigma around, but in the actual care for those people that comes through the health department.
No, thank you. And last, I think that you were highlighting issues about long-term care insurance being cost prohibitive, is there a possibility to consider what we would call similar to car insurance and what we do with MAIF to try to mitigate cost in this particular insurance area?
So I'm going to kind of not answer your question directly, but I want to answer it in this way. The issue that we've talked with, actually, the Insurance Commission about this, with the Health Department about this. This is a topic on people's minds, and we think that it requires more exploration, and it could be something. I mean, my thought is we don't know what the answer is, and so any suggestions about how we can address this issue are going to be welcome. So I think to just say we know there needs to be further study and more understanding in our state.
Thank you.
All right, any other questions? All right, seeing none, I do want to thank you. Sorry.
Thank you, Madam Chair. And I want to also extend my appreciation for your work. It is truly remarkable. My experience with government agencies over my 15 years here in the legislature has been that the agencies are very siloed. And they each have pots of money for services they are to provide, but my impression has been they figured the Department of Aging is dealing with seniors and we don't have to think about them.
Right.
And what you've done is say to them, you all have resources that you're spending transportation money on, and we have to think about transportation for seniors. So your collaboration, Jean, is wonderful, not only but also your ability to bring folks together in order to accomplish what you've done so far. And I really look forward to Longevity Ready Maryland, because 70 is actually pretty young from my perspective, so hey. But I do have a question, and this is a sort of an in-the-weeds question, but just because I'm interested in this area. You spoke about the ombudsman. Mm-hmm. What is the relation of the ombudsman to OHCQ?
It's a great question. So, quality is part of course, the overall health department. And the Office of Healthcare Quality is in charge of compliance, meeting minimal standards as required by the Centers for Medicare and Medicaid, who pay for most of nursing home care. The Ombudsman program is housed in our agency. It is a national program with state ombudsmans and then local ombudsmen underneath that. And in Maryland, the ombudsman for older people is housed in the Department on Aging. They do different things. The ombudsman is responsible for confidentially and in a protective sort of way, meeting with older people, their family members, care providers, to learn about quality issues that are occurring inside of an assisted living or a nursing home. And those kinds of things may or may not rise to the level of failing to comply with federal and state regulations for serving older people in those institutions. So while they relate to each other, and sometimes the ombudsman makes a formal complaint to the Office of Healthcare Quality, but frequently what he or she does is goes into the facility, learns what she can about what's happening, and then tries to find ways that that institution can work to resolve the issue and better serve that older person. So they're very separate and very deliberately so. And actually the ombudsman can receive complaints or concerns confidentially. And what we know is that there are people who are living in nursing homes or assisted livings that are sometimes afraid to bring their concerns forward in a more public way. And this is a way that they can be heard respectfully, kindly, confidentially, and then also, if it needs to happen, involve the regulatory agency. So that's the big difference. I've had the experience in my very long career working with state ombudsmen to do just that, to resolve issues in an institutional setting that sometimes aren't about compliance with minimal state and federal regs, but are about quality of life. And, you know, daughters worried about mothers, and why did that happen, and how can this work, or family members who don't agree about mom's care. So it's a whole range of issues. And we actually, I just want to say this, while the Ombudsman's office is housed in the Department on Aging, it is independent of my department. So the Ombudsman is not beholden to the Department on Aging when he or she is doing their work. And that's a good thing, too.
I don't see any other questions, but I do want to thank you for your passion, your commitment to serve the people in Maryland, especially, you know, this population that is vulnerable, right? And a lot of time lacks resources. My question was, and perhaps you don't have the answer, as you stated during your testimony, the Maryland number when it comes to Alzheimer's, it's quite high compared to other states. And I'd like to know, I know that we have the Virginia Jones, Commission on Alzheimer's. Do you know if they're looking at the why?
Yes.
Okay.
And that's because although there is tremendous research at the level of this is how your brain works, we know that what we think of as the social determinants of health
Yeah.
contribute so greatly to people having Alzheimer's disease that trying to make sure that that is accounted for appropriately in care models and care response is really critical. So while there's lots of work going on looking at new medicines and, trying to understand pathology in the brain, what we do know is stress caused by many, many things might be your ethnic, racial, or sexual identity can add to your likelihood of having Alzheimer's. Poor nutrition across the lifespan, poor education across the lifespan, insecure housing across the lifespan, all contribute. This is known. And so working on, I think it's a parallel path, new medicines, understanding the pathology of the disease, all this fancy stuff that's happening with genes right now, and it's kind of over my pay grade. But I understand how social determinants affect health, including brain health, and that is part of what is being looked at very seriously.
Okay. Thank you. Thank you so much. I know I learned, I was talking to someone from the Department of Health in Prince George's, how the numbers are so high in Prince George's, Baltimore City. Of course, those are, jurisdictions that have a high number of Black community members and brown people. So it is pretty, it's shocking, the numbers and the differences as well. Thank you so much. I appreciate it.
Thank you.
Have a blessed afternoon, and thank you for being with us. You're welcome here anytime. And we know that we're going to see you shortly. And do we have to go down for a minute? Okay, we're going to go down for 1 second, and then we're going to go back into it, okay? Because we're going to do the bill hearings right away. So please